Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. Simply an email will get you access to our top 200 study guide. It's a 31-page PDF, absolutely no cost to you. Lots of good reminders and things that also come up on board exams, pharmacology exams throughout your career. So definitely a no-brainer to go snag that. We also get you updates as far as when we have new content and podcasts available as well. So again, go check that out, reallifepharmacology.com. All right, let's get into the drug of the day today. That is Quinapril. Brand name of this medication is Acupril. And as you could probably imagine by that ending, PRIL, this is indicative of an ACE inhibitor. So ACE inhibitors, spelled out angiotensin converting enzyme inhibitor. It's a class of antihypertensive agents, blood pressure lowering agents. And so that's primarily what it's going to be used for. Commonly used in combination with thiazide diuretics and calcium channel blockers, which are frequently used to manage blood pressure. All right, dosing wise in hypertension, we typically like to stick with once daily dosing. Usually the kinetics allow us to do that. Most patients are probably going to start in the 10 to 20 milligram range once daily. You might use 2.5 to 5 milligrams in patients with, worse renal function, for example. But that can be a little bit dependent. Geriatric patients, another good example of a situation where we might be a little bit more conservative. Can titrate up to 80 milligrams per day in one or two dosages there. Heart failure with reduced ejection fraction is the other primary indication that I wanted to mention there. Interestingly, it is recommended to do twice daily dosing, or at least that's the way this medication was studied in the heart failure trials. So 5 milligrams twice daily with the initial goal or eventual goal to titrate up to 20 milligrams BID. So that's a targeted goal in heart failure. Now, obviously, that can depend upon adverse effects. If we're dropping blood pressure too low, we might not be able to get to that target. This is with a caveat as well. ACE inhibitors by themselves no longer recommended first line in heart failure with reduced ejection fraction. We typically want to use angiotensin II receptor blockers and nephrotoxicity inhibitors. Most common medication used there is Entresto. So guidelines tend to prefer that combination now over using just an ACE inhibitor like Quinapril on its own. All right, so getting into the mechanism here. So Quinapril is an angiotensin converting enzyme inhibitor. So ACE, that enzyme, converts angiotensin 1 into angiotensin 2. Since angiotensin 2 is a strong vasoconstrictor, so it causes those vessels to kind of close up, which raises blood pressure. By blocking the ACE enzyme, this decreases these levels of angiotensin 2 and ultimately reduces vasoconstriction, helping to lower blood pressure. Dosing, administration, I alluded to that already. Dosage forms, we've got 5, 10, 20, and 40 milligram pills. I did want to mention specifically about renal function. Generally, as renal function gets lower, we tend to avoid this, but there may be some situations where we try to use this medication anyway. Heart failure with reduced ejection fraction, for example. So as that renal function declines, we want to be more and more careful about the starting dose for sure, and we're probably going to closely monitor renal function. Okay, so kind of that cutoff that I think of is less than 30 mils per minute. But even in patients with CKD 30 to 60, we may want to be even more conservative too with that starting dose and titrate them up a little bit more slowly. So again, kind of pay attention to that. If you've got a patient with poor renal function, it's always going to kind of be this risk versus benefit assessment of what that starting dose is and or if we should use the medication altogether. All right, adverse drug reactions. So things you got to know with ACE inhibitors that are going to be tested on board exams, and something you should know for practice for sure. Hyperkalemia, so elevations in potassium. Dry cough, so if you see anybody starting cough medication, anything like that, they're reporting a chronic cough they can't get rid of, generally tends to be a dry cough. We got to make sure to take a peek at that medication list, make sure they aren't on an ACE inhibitor. Dizziness, fatigue, those have been reported as well. Obviously, dizziness can probably be associated with the drop in blood pressure, so making sure that we're not dropping that blood pressure too low. Angioedema, very, very rare adverse reaction, but we can have some swelling of the lips, the tongues, the upper airway. Pay attention to that. And then we can cause some issues with renal function as well. So paying attention to that is going to be important too. Warnings, contraindications. So there is one boxed warning with Quinapril, and it's in relation to its contraindication for use in pregnancy. Okay, so this can cause risks to the fetus, birth defects, and things of that nature. So avoid ACE inhibitors in pregnancy. Definitely a good one to remember as far as board exams and, of course, clinical practice as well. Other things that I do think about with contraindications. So if you got a patient with a history of angioedema, that's definitely something to think about. ACE inhibitors are associated with this. Recommended to avoid use with neprilysin inhibitors and angiotensin receptor blockers. So that ARNI combination, again, that's the Entresto combination I alluded to previously. And that's a 36-hour window. So you want at least 36 hours of separation from when you give one versus the other, which probably the most common situation is, maybe you've had a patient with heart failure management. They've been on a medication like Quinapril for quite some time, and you want to transition them to an ARNI. We want to make sure to have that 36-hour washout period being off the Quinapril if we're transitioning them to that ARNI medication. Also recommended to avoid this medication with aldosterone. Aldosterone's a medication. It kind of works in the same mechanistic pathway and can have some additive adverse effects there. Monitoring parameters, probably pretty self-explanatory from some of the adverse effects. So electrolytes, specifically, we're probably going to be looking at potassium there. Again, Quinapril can cause hyperkalemia. We're going to monitor renal function, and of course, we're going to check out blood pressure there as well and monitor that closely. From a pharmacokinetics standpoint, it is a prodrug. It's rapidly hydrolyzed to quinaprilat. So that is an active metabolite with Quinapril. With chronic dosing, the duration of action typically is going to cover patients as far as blood pressure lowering effect for a period of 24 hours or for a day. So we can typically, again, with this medication, get away with once daily dosing for treating hypertension. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like NAPLEX, BCPS, ambulatory care, geriatrics, BCMTMS, go check out meded101.com/store. We've got a growing list of resources there. We've helped thousands of pharmacists and pharmacy students prepare for their board exam, and we can absolutely help you too. So a great way to support this podcast is to go to meded101.com/store. Look at all the resources there. In addition, if you're a pharmacy technician, nurse practitioner, PA, med student, tons of books on case studies, drug interactions, all sorts of good stuff there that can definitely help you in practice. So go check all those out. Support the sponsor, meded101.com/store. All right, finishing up with drug interactions. First thing I try to think about is what we're trying to do with quinapril. So we're trying to lower blood pressure. So think about medications that can have additive effects and potentially oppose those effects. So NSAIDs are a good example of a medication that can that can block those blood pressure lowering effects. NSAIDs can also have additive effects on kidney function. So in a patient that's taking chronic NSAIDs or frequently taking NSAIDs over the counter, we're probably going to want to monitor that renal function a little bit more closely in that type of patient. Sticking with the blood pressure theme, so stimulants, amphetamines, these all raise blood pressure, so they can definitely oppose or counteract the blood pressure lowering effects that we're trying to have. Medications that can raise the risk of hyperkalemia. We can have some additive effects there. So potassium-sparing diuretics. ARBs are generally going to be contraindicated or avoided when we're using an ACE inhibitor. Potassium supplements. So you'd be surprised how many times I've seen that. We've got a patient that is having some issues with hyperkalemia, and either it gets missed or didn't get recognized, or the patient forgot to stop taking their potassium supplement, and that's causing an issue on top of the ACE inhibitor, for example. Some other probably less common medications, but some meds to think about, tacrolimus and cyclosporin can sometimes cause some issues with potassium levels, so pay attention to that. One I have seen in practice, an antibiotic, trimethoprim, often in the combination of sulfamethoxazole trimethoprim, brand name Bactrim. That can cause some issues in contributing to hyperkalemia as well. Again, probably not an issue. Let's say you got a 3-day course of Bactrim, 5-day course of Bactrim for treatment of a uncomplicated UTI or something like that. Probably not going to be too much of an issue there, but could spike potassium a little bit. But if we've got a patient that's taking UTI prophylaxis or antibiotic prophylaxis for some reason, probably a greater risk in that situation there. And then heparin does have some associations with hyperkalemia as well. So something to think about, maybe a little bit closer monitoring in that situation. I alluded to, ARBs, aliskiren, ARNIs, generally not going to use these medications with an ACE inhibitor. Loop diuretics and diuretics in general may pay a little bit closer attention to renal function, so it may increase that risk for acute renal failure. So again, these medications definitely used in combination, but keep in mind that it can have a little bit higher risk of causing insult to the kidney. And then last but not least, I do want to mention lithium. So quinapril can raise lithium concentration. So if you've got a patient that's got bipolar disorder, they've been stable for a long time, lithium concentrations have been pretty consistent, adding this medication could potentially alter those concentrations and increase them and make it more likely that a patient experiences lithium toxicity. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, support the sponsor, meded101.com/store. All your purchases there go directly to support this podcast. If you enjoyed this episode, please do me a huge favor, leave a rating review on iTunes, wherever you're listening. And of course, share us with friends, colleagues, students, anyone who could benefit from some pharmacology education. If you want to reach out to me, mededucation101@gmail.com. Otherwise, you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thank you so much for listening. Take care and have a great rest of your day.